So when we're doing a reassessment of somebody that's dealing with an immunologic disorder, excuse me, en route to the hospital, how you reassess the patient is going to truly depend on their stability, just like it is with every other patient. If they're unstable, it's every 5 minutes. If they're relatively stable, you might still want to go with every 5 minutes just to make sure that you're not missing them trending down because you don't want to get behind the 8 ball. If they're doing just fine, 15 minutes is just perfectly acceptable. And then make sure that you're watching for signs of shock. This can really come on quickly and take your patient down super fast. So just be very careful. Checking with your interventions. It's all going to be based on the severity of the action. Mild reactions, pretty much supportive care, monitoring. Anaphylaxis, true anaphylaxis, or moderate to severe reactions require aggressive treatment. You need to give them epi, ventilatory support for sure. Definitely should have ALS intercepting because they have a lot more medications that they can give the patient. Even if the patient starts having some serious relief during transport, you still want to take them in because the medication effects will wear off before that anaphylactic reaction is completely done. So the epi is essentially a Band-Aid. I mean, it reverses the reaction, but if whatever caused that is still in their body when the epi wears off, then they're going to go right back into it. So it's best to have them at the hospital if that were to happen. For documentation, you want to always document signs and symptoms, reasons why you chose to or did not provide the care that's expected. Sometimes what they say we should do for patients and what we actually do for patients are very different. So you need to be able to justify why you did or didn't do anything for the patient, and then your patient's response to any of your treatments. For emergency care, if your patient appears to be having a severe allergic reaction, anaphylactic type reaction, you'll do basic life support first, and then just absolute fast transport to the hospital, preferably getting ALS running as well. If there's a stinger present, scrape the skin. Don't use tweezers or forceps, and of course that's what all of our parents ever did when we got stung, or they'd pinch it with their fingers. All you're going to do is continue the envenomation. You're going to squeeze that little venom sac that's going to force that last little bit in there. Using like a card, a credit card or your driver's license, and scraping along that is going to prevent additional venom from getting into your patient. Well, it's still going to get that out. Then after you do remove the stinger, gently wash the area and just a mild soap. We don't need to use a massive disinfectant. Remove jewelry just in case that area swells. So if they get stung on the left arm somewhere, you may want to just prophylactically remove their wedding ring or any other rings they may have on their hands. If they wear an ankle bracelet or toe rings, if they get stung on the leg, just go ahead and pull that off. I mean, we don't want to have to cut that jewelry off if we don't have to, but if they have a lot of swelling and we can't get it off by the time that they get to the hospital, they're actually going to take a little device called a ring cutter, shocking, I know, and they'll actually cut off any jewelry because they don't want it to form a tourniquet around a finger, a leg, or whatever because of swelling. Try and position that area of envenomation below the signs or below the level of the heart, just to try and prevent some of that swelling. And that's if you can, little common sense there. Apply ice or cold packs to the area, but not directly on the skin for more than 10 minutes at a time. We try not to apply cold packs directly to the body. You always want to have some sort of protective layer between it. So a towel or a pillowcase put that on first and then put the ice over top of it. It prevents you from freezer burning or ice burning the patient's skin. We're constantly watching for signs of airway swelling. They may be talking to you just fine when you first show up, and then all of a sudden they start to slur their words, they're drooling a lot more. That's a terrible, terrible sign. If they progress from slurring to not being understandable because their tongue has gotten so big, or they start gagging on their own tongue, things are not going well at all. If the patient is showing signs of shock, we want to try and keep them in a supine position. Again, if they're having a hard time breathing, they've got airway swelling, etc., they're not going to want to lay down. People that are short of breath inherently want to sit up. So position of comfort is going to be your best bet, and then give them oxygen as needed. Make sure that you're monitoring their vital signs. You should always take a set of vitals before you give an intervention and then after you give an intervention. And that's not part of your 5-minute or 15-minute intervals. It's to see what has changed after you provide a treatment to your patient. As EMTs, it's not typically as important because most of the things that you'll do for a patient are just going to be basic positioning, some oxygen, maybe assisting with a couple of medications, but it's not huge at this point for an EMT. But you need to get in the habit of it, because eventually a lot of you will hopefully go on, gain some experience, and start working on more critical patients. So that's definitely a good habit to get into. It's just like when you splint a limb and you check for CMS or PMS, however you want to say it, circulation, motor, and sensation. You check before and you check after. Same thing with vitals and medications or oxygen. So the medication that we provide is epinephrine. It's a hormone that is actually naturally made in your body. We just give you an extra jolt of it. And this is what mimics that fight or flight response. The common name for it is adrenaline. There's several different properties that epi has. One of the things that it does is it binds to an alpha-1 receptor. No, you're not required to know that, but it binds to an alpha-1 receptor, which causes your blood vessels to constrict. And then it binds to beta-2 receptors, which cause your bronchioles and bronchus in your lungs to dilate. So it has two very different responses because of the type of receptor that it binds to. Epi also increases cardiac contractility. So that is one of the side effects. A patient that's already short of breath, if we start increasing their cardiac contractility, their heart's going to be working harder and they're going to need more oxygen. But a little bit of an increase in heart rate versus not being able to breathe or not having a blood pressure to perfuse the majority of the body, including vital organs, it's kind of a toss-up. So what you guys will be end up giving here is an EpiPen. So it's a pre-measured dose. If you get ALS on scene, they can actually give IV epi. Works a lot faster. You don't have to worry about absorption, and they can give much greater doses. There are 2 pens in most of the packs. So if you give one and it doesn't work, then you can give another one. The adult EpiPen delivers 0.3 milligrams of epinephrine. The child infant one, the junior, delivers 0.15 milligrams. Make sure that you check it for those rights. So is it the right person, the right time? Is the right date on there, the right dose? You know, you have to go through that just to make sure that you're safe. There is a skill drill for this. So it's 20-1, how to use an EpiPen auto-injector, and we've got one as well. To actually work it, you'll take off that gray cap that you see, and you press it firmly into the outside of the thigh. You don't need to remove clothing prior to. And once you feel it inject, then you hold it there so that all the medication can make sure to get into the leg, and then you pull straight back out. It's quite an impressive needle on the end of that. So be very careful with it. Don't nab yourself with it, basically. Epi can have an effect within 1 minute given IM, which is intramuscular. So it does work pretty quickly. You'll know if that first 0.3 is not working. So you can give a second dose. You're going to want to check a blood pressure after you give it, because now instead of going from that low blood pressure, that mildly low blood pressure, it actually can spike their blood pressure. An increase in pulse rate, because they increase that cardiac contractility. Anxiety, it does tend to make patients a little jittery, a little nervous. Cardiac arrhythmias, because if the heart is already not getting enough oxygen, if you increase its oxygen demand and it still doesn't have enough to balance out, the heart gets really, really angry. And so it'll start beating or throwing electrical signals where it's not supposed to. Pallor just means they turn pale. Dizziness, chest pain, headache, nausea, vomiting. I would say pretty common side effects. So who don't we give epi to? If patients don't have signs of respiratory compromise or hypotension, and they don't meet the criteria for a diagnosis of anaphylaxis, we're not going to give them epi. If they've got a couple of hives on their arm that just itch really, really bad, or they've got a little bit of a red rash on them, there's no need to give epi. Epi is going to work on the blood vessels. It's going to work on the lungs. It's going to work on the heart. It doesn't do anything for the skin. So if they're just having a skin reaction, epi is not going to do anything, but you're still going to have to deal with all of those side effects. So it's a benefit versus risk. Patients that are having the issue of itching and whatnot on their skin, Benadryl is much better for that. So that is about all I've got for this.